the clock says it's 12, so I'm going to start. And welcome, everyone. I'm Carol Runyon. I'm a faculty member in the Department of Epidemiology and also director of the Program for Injury Prevention, Education, and Research. We are co-sponsoring this seminar, I'm pleased to say, with Piper, the group I just mentioned. I will go through it again. The Preventive Medicine Residency Program and the Department of Epidemiology. And we're very pleased to have a special guest with us today, who I'll introduce in just a moment. But before I do that, I wanted to draw your attention up here to our next two injury seminars that are scheduled. On March 8th, we'll host Andrea Gielen from Johns Hopkins University, a leader in doing child injury prevention. And then on April 19th, Ingrid Binswager from Kaiser and from the Department of Medicine here, who is active in doing work on prescription drug overdose. So put those on your calendar and watch for notices about the exact placing. And welcome. And so I would also like to give our speaker just a little idea of the mix of people in the room. How many of you are students here on this campus? In the health sciences, okay. How many are preventive medicine residents? Maybe it's some of the same people. How many are faculty from this campus? State Health Department and other community members. Did I miss anybody? Good. Local Health Department. Great, great. So we have quite a mix, and it's wonderful to see a mixture of academic folks and practitioners and people of in different disciplines. So our speaker today is Dr. Alex Crosby from the Centers for Disease Control and Prevention, where he is the branch chief of the surveillance branch within the Division of Violence Research, Violence Prevention in the National Center for Injury Prevention and Control. How'd I do? That's a lot of acronyms. He also has an adjunct faculty appointment in community and health and preventive medicine at Morehouse School of Medicine. He's trained as a physician at Howard University and with an MPH in health policy and management from Emory University, and completed 2 residencies, one in family medicine at Howard and a general preventive medicine residency at Morehouse and with the Georgia Division of Public Health. So he's got a rich background. He's been at CDC almost 3 decades and is the head honcho on suicide, even though that's not his particular title, but I know that to be the case. So we're very pleased that he came today to talk about suicide as a public health issue nationally and in Colorado, and will give his presentation. And would you like questions as you go or at the end?
They can do them as I go.
Okay, there you go.
All right. Well, thank you. And I think I've got this right here. Pop it 3 or 4 times. Well, good afternoon to all of you, and thank you all for coming and paying attention, spending your lunchtime here. I see a few of you brought lunch. I don't know the rest of you should have brought it, because I hope I'm going to keep talking and you don't have any plans for dinner, because we're gonna talk on for a little while today, and hopefully we'll get some things settled. You know, given the diverse group that we've got here, it seems like we ought to have some meet and greet here before I talk. You know, folks from the local health department, state health department, students here, faculty, those from probably from the School of Public Health, those from the preventive medicine residency. So quite a big group here that we could probably learn from each other. You probably don't need to listen to me very much, but talk a little bit amongst each other. So I am going to talk about the epidemiology and prevention of suicidal behavior. I do want to thank the organizers for the invitation to come and to talk to you from the various groups that have invited me to come. And as I talk about this, one of the things in terms of thinking about why this is important and why we want to, at least us at CDC, want to talk about this as a public health issue is that oftentimes when you think about suicidal behavior, you oftentimes think about it as solely a mental health problem or a mental illness problem. And really, when you start looking at the risk factors and you start looking at the science and you start looking at the protective factors and how things play a role in suicidal behavior, it actually is a broader scope of the different things that play a role in that. One of the things that we're taught at CDC, and many of you who have done any kind of outbreak investigation get taught, is you kind of look for the sentinel case, or you look for that thing that's the index that might give you the clue for the rest of what's going on. But I just want to use that as an example for some of what I'll talk about today. Some of you may be familiar with a couple of articles by Case and Deaton. These are Princeton economists that have tried to look at some of the things that have been going on in the United States, especially in what they call these diseases of despair. And what they've started to look at is in the United States, especially over the past couple of years, when you've looked at life expectancy in the United States, it's dropped. You know, in 2015, it dropped from 2014. In 2016, it dropped from 2015. And that's an unusual trend. For the most part, especially throughout most of the 20th century, life expectancy in the United States has been going up. You know, we've been living longer and living longer and living longer. But the past couple of years, it's been going back down. And so one of the things that Case and Deaton try to make the case for, right, Case and Deaton, is that they talk about these diseases of despair and three things that they think are contributing, three things in terms of mortality that are contributing to that. One is overdose poisoning deaths, another is chronic liver disease deaths, and the other is suicide. You know, are these some things in which we might talk about an index case or an index type of condition that might be cluing us into what's happening in the United States that we might need to pay attention to in regards to what's going on with life expectancy here in the United States? I'll go ahead and start talking. I do like to point out to people down at the very bottom there is the disclaimer that they make us put on all of our CDC slides. So I like to point out to people that in case I say something that gets you on edge, makes the hairs on the back of your neck stand up. What that sort of says is like the little piece in Mission Impossible that, you know, if any of your group are caught or killed, the secretary will disavow any knowledge of what you did. So I'm going to tell you now that the current acting director of CDC is Dr. Ann Schuchat. So if it turns out I say something and you get upset, Ann Schuchat, that's her name. You can send something to Ann Schuchat and tell her this Crosby guy came there. He had the uniform on, the whole business. And she will say, I don't know who he is. Never heard of him. Whatever he said, that was on him. It was nothing. So it does say that should not be construed to represent any agency, determination, or policy. Disclosure statement, this was just in case, you know, because sometimes I have to go to the medical conferences and they say, you know, no financial relationships to disclose. I was going to crack a joke about our previous CDC director. I'm not. Move on. This is being recorded, right? So there's only certain stuff I can say. Learning objectives for today. At the conclusion of this session, hopefully you will be able to describe why suicide is an important public health problem, discuss the parts of the public health approach, and I'm going to talk a little bit about the National Violent Death Reporting System. We have a few folks in the room that work with the Colorado Violent Death Reporting System, so I'm going to give a plug for them also today and show you some of the data, and especially those of you that might be doing analyses, you know, whether it's for your master's thesis or your doctoral dissertation, and I don't know how many of you have to do original data collection. I am here as a proponent of secondary data analysis. Some of your professors will tell you that's a little bit easier, IRB stuff. Anyway, but just in case you want to use the Colorado Violent Death Reporting System, there's a lot of information in there. So keep that in mind as you go through in your, if you haven't decided on, you know, what to use, and suicidal behavior is an important one to try to take a look at. Why is suicidal behavior an important public health issue? One is the morbidity and the mortality that suicidal behavior is responsible for. The 10th leading cause of death in 2016, that's the last year for which we've got full death certificate data for. Over 44,000 deaths in that year. That averages out to about one death every 12 minutes in the United States. And that's important. When I used to do some of these presentations, and especially go back about 7 or 8 years ago, in which deaths due to suicide were around 30,000. You know, I used to talk about a death, you know, every 20 minutes. And then it got up to about death every 15 minutes. And then a death every 14, and then a death every 13, and now it's a death about every 12 minutes. So suicides have been going up in the United States. So it's an important thing for us to pay attention to and also see where these trends are going the wrong way from what we'd like to see them do in terms of going down. They're actually going up. It's increased 20% since 1999. There's an estimated over 500,000 emergency department visits for self-inflicted injury. So that includes not just suicide attempts, but also other forms of self-harm. And there are many consequences across a number of different health outcome areas, not just physical, but mental and behavioral. There's also a potential for impact from public health. And so if public health really didn't have anything to bring to the table, if you will, if we didn't really have any tools or any skills to add to the discussion about what to do to prevent suicidal behavior, then probably we should be quiet about it. But I think our focus on prevention, the science base, especially epidemiology, and then stressing that multidisciplinary approach are things for which public health helps bring others and have that conversation about what are the skills that you have, what are the strengths that your group has. So when we're talking with the education folks, or we're talking with the social service folks, or we're talking with the criminal justice folks, or we're talking with the folks from the business sector, all of those different organizations, the faith-based organizations, how do we all work together on this issue? Suicide really is a societal problem. And so it takes all of those different kinds of organizations, all of those different kinds of sectors working together to really make a difference in it. It's not just public health by itself. I hate to break this to you, all you students in MPH school. I know you came to solve the problems of the world. Can't do it by yourself. You got to work with other folks in order to do that, in order to make those things happen, that you've got to work with other disciplines, other sectors in order to do that. One other thing, just to, again, I hate to do this sometimes, that I break, bust the bubble of the MPH students, because I do have an MPH myself. But if you went into the MPH to get a lot of money, I am so sorry. I'm so sorry. I'm so sorry that I have to tell this to you today, that you're doing it because you believe in social justice, and you believe in helping people, and you believe in helping to deal with the problems of society. But if you're planning on getting rich quick, no, that's not going to happen. This also fits with suicidal behavior, and preventing it also fits with the mission of public health. And here, just a quote from John Last's Dictionary of Epidemiology: reduce the amount of disease, premature death, and disease-producing discomfort and disability in the population. So I think that fits with what we do in regards to public health and the public health approach. This is the public health approach, kind of depicted as 4 different stages, and I try to depict it as kind of a cycle that while I say you start off with assessing the problem, oftentimes in public health we're doing all 4 of these things at the same time. There's very few things for which we have solved that problem throughout the human population. So this is another question. Seems like I'm picking on the MPH students today. I'm really not trying to pick on them. But they should know, there's only one disease that we've eradicated, right, from the population. That's smallpox. I knew you guys were all going to raise your hands. You were all going to say that, right? Smallpox. But even with smallpox, we're worried because they got it in labs somewhere, right? The United States, we got it in labs. The Russians got it in labs. So we still inoculate, the military folks for smallpox. So there's only one disease that we've eradicated. So for everything else, whether it's tuberculosis that's been around for millennia, or you're talking about all kinds of other things, suicidal behavior included, we are doing all of these things at the same time. So we assess the problem, trying to figure out what the who, when, where of that particular problem is. What's the problem? Identifying the causes, trying to identify the why of that issue, then moving on to the purple, which is developing and evaluating the programs and the policies. What works, what doesn't, taking that information and moving on to that orange, implementation and dissemination. Now, how do we spread the news? How do we tell people what to do, what not to do? And how do we take that from a pilot program to a program we're going to spread across the country or across the world? So all of those kind of things. And now how do we apply that to suicidal behavior? So starting off with assessing what that problem is. And I'm going to show you some of the data that we've got and that we collect, as well as other groups that we work with collect regarding suicidal behavior. So you can see that suicide was the 10th leading cause of death in the United States overall. When you look at all the deaths that occurred there, over 44,000, almost 45,000 deaths. But then when you look at it by different age groups, it looks a little bit different. So overall 10th, especially when you look at adolescents, young adults, those 10 to 14, 15 to 19, in their 20s, in their 30s, the 2nd leading cause of death. So disproportionately, suicide as a cause of death disproportionately affects young people. in the United States. So it's something that we really need to be paying attention to in regards to, we're going to start developing a prevention program. That's what the public health approach is trying to get us to do. We want to assess what that problem is, identify the causes. We're trying to move towards the implementation and dissemination. We need to know what's going on among young people. Even in the 40s, it's the 4th leading cause of death. Those in the 50s, the 7th leading cause of death. Here, when you look at leading causes of death by ethnicity, you can also see it disproportionately affects different groups here. Whether it's the 9th leading cause of death among white, non-Hispanics, among American Indians, Alaskan Natives, the 8th, among Asian and Pacific Islanders, the 9th, and then you can see among Latinos, it would be down there in number 10. So it affects different populations in different ways, so something that we need to understand in regards to thinking about our prevention programs and thinking about the magnitude and the scope of how this problem affects different populations. Here's suicide rates as you look at them across most of the years that we've got vital statistics for. So our death certificate data goes back to 1933, in which we've got all 48 states at this time. So I'm not going to say anything today in PhD thesis. This will be to the preventive medicine residents. But I only saw one person raise their hand as a preventive medicine resident, so I can't pick on him all by himself. That's really not nice. But you can see the highest suicide rates we ever had were back in the 1930s. There was something going on, an economic phenomenon going on, right, in the 1930s? So while we talk about suicidal behavior, especially as it relates to mental illness, here's an economic phenomenon, the Great Depression, that led to some of the highest suicide rates that we ever had. And some of you, I can see it on your face, you're thinking right now, the Great Recession, right, that happened in the mid-2000s, 2007, 2008, 2009, and especially when you look out here at males, the overall, at females right there, that suicide rates were also increasing in the United States during that time. It actually started a little bit before the economists declared the Great Recession really started, and has continued even after the economists had said the Great Recession is over. But we know that had some sort of influence on suicide rates in the United States, the economy. Not just the only thing, but as I talk about this a little bit more today, that there are a number of different influences, but that's one of them. One of the influences of suicide in the United States has to do with the economy. I have a colleague, if you look at this right here, the little blip right here, she has a theory about what that is. I'm not going to tell you. If you want to ask me a question, I'll tell you her theory, but she has made me promise, so I'm going to make you guys promise too. You can't write a paper on this, because she hasn't written her paper yet. Now, it's been at least 10, 15 years since she came up with this theory, but she has never written a paper on why she thinks we had that little bit of an increase. We'll see. I'm going to talk a little bit more about it, and if you guys have a question, we'll see what we can get to. This is describing the pattern when you look at males versus females. So again, understanding that what part, that assessing the problem part, 10th leading cause of death, but different when you talk about different age groups. When you look at males versus females, suicide rates about 4 times higher among males than among females, and especially when you start looking at older adult males, those over 65, that rate just really, really goes up. The highest rates among females tend to be in the middle age, but among males, it's those over 65. So understanding what's happening with the patterns. One of the things that has changed over the past few years, especially since about 1999, I said the rates have gone up about 20%. One of the things that's changed, it used to be the highest rates were among the elderly in the United States, those over 65. What you can see from this one, especially when you look at the blue boxes, is that now the highest suicide rates in the United States are among middle-aged adults, those in their 40s, 50s, and 60s. So a change in the pattern here in the past few years, again, as we understand what that pattern is, what's that telling us about what we need to understand about risk and protective factors, and then about prevention activities. If we're really going to try to impact the problem, where now is the bulk of suicides in the United States? It's among those middle-aged adults. We're not forgetting about some of the other populations, but here's where, if we want to try to make a major impact, that might be the population that we've got to focus on. Different patterns when I look at it by ethnicity, white non-Hispanics, American Indians, Alaskan Natives. You can see some very different patterns here among American Indians, Alaskan Natives. Highest rates among adolescents and young adults. When you look at white non-Hispanics, which is the green, highest rates among those in the middle age. So different patterns. Again, where am I focusing my prevention activities? Where am I focusing my resources? It may be different depending upon which communities you're talking about doing your prevention program in. Here's the method, and you can see that just over half of the suicides in the United States, a firearm is a method, followed next by suffocation, that's oftentimes hanging, and then poisoning the third. This is the pattern when you look at it around the United States, and just to show you that it's not evenly distributed all over the country. And for a long time, when we've looked at the age-adjusted suicide rates in the United States, and that's, so you can take into account the fact that suicides don't occur evenly across all age groups, that the Rocky Mountain states tend to be the top 10 or 13 states every year when we look at suicide rates in the United States. Colorado is the 9th leading state in terms of suicide rates in the United States. One of the things that was a little bit different about this one, and I don't know who put this map together, that Arizona, I don't know what I was doing. The other ones, the crosshatch looked okay, and Arizona, I did something strange. I don't know what I was doing there. But this is one of the few years that Arizona wasn't in the orange, but they're in the second group, just behind the orange. So they didn't go down very much. But yeah, those Rocky Mountain states and Alaska, every year, when we look at the age-adjusted rates and rank them by state, those Rocky Mountain states are the top 10 states or about the top 13 states every year. That's one of those things. So here's another. This is, again, back to the MPH students. So the Nobel Prize, they give that out every year, right? It's about $1.3 million, I think, now. So if you guys can solve that thing right there, and when you get up there to win your Nobel Prize, I don't want a piece of the check, even though I gave you this idea, so I want you to know I gave you this idea. I just want you to give me a little shout out when you get up there. You'll just say, Alex Crosby, he gave me this idea back in 2018. When you win that Nobel Prize in 2025 or something like that, just mention my name. You can keep the whole 1.3 million. You don't have to send me $1. No, just mention my name when you get that answer. And just in case you're still looking for that master's thesis, that might be the thing to take a look at. This is some of the data that comes from the Colorado Violent Death Reporting System. So you can not just look at it by state, but you can look at it by county. I do have to make an apology here. I don't know if there's anybody from Broomfield County here or lived there or driven through it. I don't know where this map. I went and got a map of Colorado, a little PowerPoint map. There's no Broomfield County on here. So I don't know, what in the world happened to it? I don't know. And maybe this because the map from like a 2003 map. Broomfield County is right up in here somewhere, and they should be in the beige and the brown, right up there. But I don't know. It was gone. I'm going through, putting the colors in and everything. Broomfield? Wait a minute. Huh?
They don't get mail there either.
See, I don't know what to do. So yeah, it's quite a challenge. But you can see that even when you look within counties and you look within communities, and even if you probably drilled it down to the level of a census tract or a neighborhood, that there's some differences there and some things in which you start to look at, some of the factors that play a role in suicidal behavior that differ across different populations. It's something you will want to pay attention to and try to answer. The suppressed just means that there were less than 20 deaths in those counties, and so we don't put the rates there. The unreliable means there's less than 10 deaths in those counties. And some of those counties, especially in some of the rural counties, they can have very high rates, even though there's a very few number of suicides in those counties because the populations are very small. But they can be unreliable because those rates can jump up and down quite a bit. All right, this is some data that we just recently released from CDC in which we looked at the differences by urbanicity. So whether a county was, kind of a core metropolitan county out to, the counties that might be more rural. A couple of things I think from this particular slide. One is that you can see that across the time period from 99 all the way through 2015, the non-core, or these were the most rural counties, always had the highest suicide rates. The other thing to look at here is that those core urban counties, when you kind of compare the difference here in 1999 compared to the difference out here in 2015, what that's showing you is that the rates in rural counties have been going up faster. So not only did they start out higher, stay higher, but they've been going up faster than rates going up. Even though they've been going up all across the country, they've been going up faster in the rural areas. So again, something for us to pay attention to in regards to looking at where we want to focus prevention activities and looking at populations that might be at risk. All right, suicide variables. This is a little bit from the violent death reporting system. I told you I'm putting out, a little bit of, promotion for the violent death reporting system. Within that system, these are all the variables that we try to look at in regards to suicidal behavior. From current depressed mood, which is a much more subjective one, to other ones that are more objective, looking at school problems, financial problems, whether the person left a note. I'll show you a little bit about some of the data from 2014, in which we've got 18 states. Currently now there's 40 states in the violent death reporting system, plus Puerto Rico and DC. So we've expanded the number of states that are in that system. This is 18 states that we can compile back in 2014. But you can look at those that died as a result of suicide, how many versus males versus females, how many were reporting intimate partner problems, physical health problems, financial problems, how many left a suicide note, history of suicide attempts, crisis in the past 2 weeks, and recent criminal legal problems. One of the things that we've noted when we look at those that die as a result of suicide is that oftentimes relationship problems are one of the things that are in there. Again, kind of pointing to why this is a big public health issue and not just a problem that's isolated into one particular realm, but something for us to really look at. These are some of the more mental health related issues that are in the violent death reporting system. Current depressed mood. What we ask in that one is we ask those friends and family members, the next of kin, whether the person appeared to be depressed. So we're not asking for whether they were ever diagnosed, but appeared to be depressed. And you can see that almost 40% across males or females. Then we ask whether that person had a diagnosed mental health problem, whether they were under treatment, had an alcohol problem or other substance problem. And you can see some of the data from that there. One of the things to understand, and I've talked primarily about deaths up till now, is that deaths are really just the tip of the pyramid when you talk about the burden or the scope of the problem in regards to suicidal behavior. That fatalities are just one little piece. When you look at hospitalizations, emergency department visits, events on surveys, that the numbers are even bigger. So here, just looking at some of the data from 2014, there were 42,000 deaths, 128 hospitalizations, almost over 400,000 emergency department visits. So just in the next one, I'll kind of show you a ratio when you just look at adults, that for every one death, and you go down to the bottom, in which we look at a survey that asks about, did you seriously consider suicide in the past 12 months? So for every one person up on top that died every one adult that died as a result of suicidal behavior, you've got over 200 that say that they seriously considered suicide in the past 12 months. One of the things we know about those that die as a result of suicide is that one of the biggest risk factors is those who have made attempts in the past. And that might be looking at that next to last category, that over 1 million adults in that survey said in the past 12 months, I made an attempt. Now, not all of them appear in an emergency department or come to see a clinician or tell any medical professional or healthcare provider about it, but that's an important population for us to take a look at. This is one of our data systems that looks at emergency department visits for self-inflicted injury around the country. We have a number of Sentinel hospitals. We work with the Consumer Product Safety Commission about this. One of the things to show you that's different here than when I show you the mortality, that males die of suicide about 4 times more than females. But when you look at the non-fatal, you can see in almost every age group, the orange, which is the females, are higher than the males, especially when you talk about adolescents and young adults. So females are at least being seen in the emergency department, and when we ask on surveys too, it tends to be the case. Females report more suicidal behavior, non-fatal suicidal behavior, than males do. This is from the Youth Risk Behavior Survey, a high school survey in which we ask a number of questions among high school students around the country, 9th through 12th grade, things like driving history, about nutrition history, about exercise, about substance abuse. And there are 4 questions that specifically deal with suicidal thoughts, suicidal plans, attempted suicide, and suicide attempts that required medical attention. Here again, just to show you that for each of those questions, seriously consider suicide, made a plan, made an attempt that required medical attention, females report more than males. This one is for the MPH students. Those are statistically significant difference across each of those. So you guys all know what that means, right? Of course, that's epidemiology 101, right? You guys all did all that stuff. This is specifically looking at that question on suicidal behavior. In the past 12 months, have you made a suicide attempt? And just to show you kind of what the trends are, and again, kind of the difference between males and females. Every year, females report more. And again, kind of the last few years, from the 2009 up through the 2015, females have been going up. Males has been kind of staying flat, but females have been going up in regards to reporting suicide attempts in the past 12 months. This is looking at suicidal behavior among high school students by sexual identity. One of the things they've done to adapt the Youth Risk Behavior Survey around the country is many states had the option of adding the questions about sexual orientation, sexual identity into their survey. As you can imagine, that's a tougher sell in some states than it is in others. But one of the things they've tried to now put into the core part of the Youth Risk Behavior Survey, so that all states are doing it, are asking these questions about sexual identity. Here, just to show you that those who report LGB behavior or same-sex behavior will tend to report more suicidal attempts than those of other populations, compared to especially the heterosexual behavior. This is one, I'm not sure that I want to go into a lot of this one, but this is one in which we looked at the National Survey on Drug Use and Health that surveys adults and has some questions about suicidal behavior, in which what we did is we looked at it by occupation. And where I've got the circle is those who were in finance and management, that their average was about the national average. But you can see in terms of certain occupations, it tends to be very high. One of the things about this that kind of surprised us is when you look at the farm right there, and it was lower. And when we had looked at the rates of suicide rate, and that rural areas have higher suicide rates than others, we were expecting those in the farm sector to be the highest. But no, they were the lowest. All right, that's another puzzler for you MPH students to try to figure out what's going on here, that those in the farm industry reporting lower suicidal thoughts than others. Now, this is thoughts. This is not behavior. So there may be something else going on with this that we don't know exactly what. So I've spent the first half an hour in the first box. I told you, no dinner plans, right? Because I haven't even gotten to the second box yet, and it's already 12:30. And nobody's asking any questions either, so we're rolling along here, seeing what's going on. So let's try to talk about identifying the causes. Why did it happen? There will be a quiz after today to see if you can reproduce this. This one is, just to give you an example, this one was put together by Michael Phillips, who does a lot of work on suicidal behavior in China. But just to show all of the different influences on suicidal behavior, from looking up at the top, external influences, kind of going down the side, socio-political factors, socioeconomic environment, personal resources and stressors, biological and psychological status, social identity, interpersonal networks, cultural factors. All of these things can play a role in suicidal behavior. One of the things that we'll maybe talk about a little bit before we get to it later is that you don't have to stop every single one of these things. Is that oftentimes in terms of breaking the cycle, you can develop interventions that might influence just one of these boxes, and you can make a difference in regards to lowering suicidal behavior in a community. So just one example of the complex issues regarding interaction of different factors. This one's a little bit simpler, so a little Venn diagram looking at the individual level, peer and family level, community level, societal level, and some of the different factors that might be in each of those different circles, and thinking about where an individual might be at greater risk for suicidal behavior. If they have risk factors that exist at the individual level and at the peer and family level and at the community level and at the societal level, they might be someone that's right in here and have the most risk factors and might be the person that's at greatest risk for suicidal behavior. There's a number of different things here in different studies that have tried to look at this. A few of these are protective factors. And so I'll show you over here, when you look at the community level, factors that spirituality is actually a protective factor against suicidal behavior. When you look here at social isolation versus social support, that's kind of the network of friends and family that a person has. Social isolation being the risk factor. Those that don't have that network tend to be at greater risk for suicidal behavior. Those that do have that network, the social support, tend to be at lower risk. Here's the population attributable risk, one study done by Lee et al., in which one of the things that he seemed like he was trying to point out with this study is that you look at some of those mental health factors, and they are big factors in terms of over 20%, over 30% that they feel are attributable to suicidal behavior. But then he also wanted to show some of those socioeconomic factors in terms of education and occupation, that those can also be big factors in regards to things that play a risk in regards to suicidal behavior. I did that one kind of quickly. So now we're on developing and evaluating the programs and the policies. So we'll talk a little bit about some of those. One of the things that CDC has done recently, last year, and then I think towards the end of 2016, is we put together these technical packages. And this was based on an article that our former director, Dr. Thomas Frieden, put together, in which he talked about some of the things that you really need to have in place in order to help communities develop effective prevention activities, and technical packages were one aspect of that. So this is going to be just a little bit of I'll call it a grace note. Those of you that know a little bit about music, you know, a grace note is when the musician throws in an extra note into the music, you know, to enhance the music. So I'm going to give you a little bit of a grace note. So when Dr. Frieden, who at the time was our director, wrote this article, you know, and he distributed it to everybody. So if you are an employee, especially a scientist at CDC, and your director sends out an article that he wrote, it behooves you to read that article. I'm just letting you know that, you know, those of us who kind of took that seriously said, Dr. Frieden wrote this article. He's sending it out. I think we better read this. And not only that, so we in the Injury Center, we decided we're going to take this a little bit further. We're actually going to write some stuff about the article that Dr. Frieden just sent out. So we're actually going to produce it. You know, we should have got a bonus and 6 weeks paid vacation or something. You know, but we did, you know, acknowledge Dr. Frieden that he talked about these technical packages, which are really, you put together some of the evidence-based programs that are in a particular area. And so for us, we went through some of the ones in violence prevention and developed this list of evidence-based programs in these particular areas: child abuse and neglect, sexual violence, youth violence, intimate partner violence, and then suicidal behavior. And you can see there down at the bottom, that's the website, so you can go and take a look at it. I'm going to talk a little bit about the technical package on preventing suicide. This is a little bit about our process. You know, that we went through, we reviewed the literature, identified the strategies and approaches, developed a draft, had it reviewed by some of our external partners, and then editing and formatting for the final product. And then we came up with this document. I won't go through all the details, but we had 7 different strategies for which we found that there was evidence that these things actually worked in regards to suicide prevention. One of the things that I just want to point out to you is that not all of these, a few, but not all of these actually have suicide prevention in their title, especially when you look at that top one, strengthening economic supports. And I pointed out to you highest suicide rates we ever had in the United States during the Great Depression, what's been happening with the Great Recession. And so we found that there were some places in which they had evidence in which they developed programs that are more focused on economic security and actually showed that it had health outcome benefits. So we included some of those in that one. This is actually one of the ones that cuts across several of those different technical packages across some of those different areas in terms of violence. I know it's in the child abuse and neglect activity, their technical report. It's in the youth violence one. I think it's also in the intimate partner violence one, that strengthening economic supports has a lot of wide-ranging impact across different forms of violence. And not just there. You know, we've talked with some of our colleagues. Just to let you know, us in violence prevention, we do talk to the HIV folks and the chronic disease folks, and we talk birth defects. We talk. So I hope you guys do that same thing too, right? you talk with some of your colleagues in the other disciplines. Okay, I'm just letting you know. That we talked with some of them, and they also had some evidence that in other places, that some of the prevention activities that are focused on specific health outcomes, there's an economic component to them, and that they've shown that there's been some impact there. So I'll go down these and just talk about this list a little bit. You see some of the approaches that are a little bit more specific about some of the different activities, and then we actually list out some of the specific programs. So that would have been the next column over. You've got to read it. You got to read the actual document to get all of those details so you can get all of that stuff. But strengthening economic supports was one of the strategies, strengthening access and delivery of suicide care, creative protective environments, promoting connectedness, teaching coping and problem-solving skills, identifying and supporting people at risk, and then lessening harms and preventing future risk. So all of those 7 strategies had some evidence, and there are some of the different approaches that get more specific about incorporating into some specific things. There are also some examples of integrated or comprehensive programs of which they tried to put together multiple types of strategies. United Nations and World Health Organization made some recommendations about nations developing national suicide prevention strategies in which that country should put together multiple strategies using multiple sectors. And the U.S. Air Force, back in the mid-1990s, developed some strategies for putting together multiple components of these different kinds of programs that also showed that they were pretty effective. I just wanted to show you this one because it deals with the aspect of looking at means safety. And that many people are not too convinced about this, but there's a lot of evidence internationally that this is one of the types of programs for which you look across the world, and those who have studied this have found some evidence that means safety can actually make a difference. This is one in which in American Samoa, they had their rate of suicides were moving along. It had gone up a little bit. And then paraquat, which was a pesticide, and it's one of those old organophosphate, like DDT type of pesticides that I kind of characterize as it's real good at killing bugs and insects, and if you put it in your mouth, it's real good at killing you too. And so what they found is that they introduced this with not a lot of restrictions on who can go out and buy it. And you can see what happens in the blue line with the pyramids is that suicides start going up, and especially paraquat-related suicides start going up. They recognize this because of the data. They put some controls in place, and suicide rates drop down dramatically. One of the things when I first started looking at some of this stuff regarding means safety is I thought, well, can't people just go out and try something else? There's no pesticides, but they can just go out and grab some other pills, or they can just go and do something else. But it turns out a lot of people don't substitute another means. And it just has to do with the nature of suicidal behavior. Some of it is impulsive nature, and that is a restriction. Also, it has to do with kind of the restricted thinking of some people that are contemplating suicidal behavior. But consistently across the world, when you control for a highly lethal and highly accessible means, and you make that means less accessible, you see a drop in suicides that's not compensated by, we do something like with bridge barriers, where you put a bridge barrier on this bridge, and a mile down the road, there's another bridge that people can go down to. You don't see an increase in suicides at that bridge a mile down the road. So there's something about this means safety mechanism that is effective and works. And so it's one of the things that we talk about in that technical package, in terms of across a number of different means, that you can make these highly lethal, accessible means less accessible and make a difference in suicide. All right, implementation and dissemination. We might finish before 2050, something like that. So implementation and dissemination, so how do you do it? One of the things that I'll mention here, and I'll talk a little bit about the national strategy as one of the things that we talk about in this area of implementation and dissemination, is that in order to make health policy change, one of the things that Julius Richmond, who was a Surgeon General back in the 60s, I'm not sure if it was under him, but it was close to it, when they first put that message on the package of cigarettes, about cigarette smoking can be harmful to your health. I think he was the Surgeon General, or he was the one right after, in which they first started putting that message. So he's one of the ones that came up with this. You need political will, you need the knowledge base, you need the social strategy in order to change health policy. And so back in the early 2000s, when the first national strategy came out, we thought we had those three things: the political will to talk about a national strategy for suicide prevention. We had the knowledge base. We knew enough about the patterns. We knew enough about risk factors and protective factors. We weren't perfect because we're still learning stuff now, and we knew enough about a strategy about what to do that we could start and make this recommendation for putting together this strategy. So the most recent one is the 2012. This is the second version, 2.0, of the national strategy. It's got 4 strategic directions, 13 goals, 60 objectives. Those 4 strategic directions have to do with healthy and empowered individuals, families, and communities, clinical and community preventive services, treatment and support services, and then surveillance and research. So we believe that that strategy, that national strategy, as we start to implement it across the country, and many states have taken some adaptation of that national strategy and developed their own state strategies to mirror that. And then some communities, too, have done that same kind of thing, that those can be effective. So what is CDC's approach? We want to try to examine a broad perspective, support collaboration across disciplines, so not just public health, but mental health, medicine, education, social service, criminal justice, etc. Strengthen the information. That's one of CDC's historical strengths, is the data and the epidemiology. So we want to make sure that's as strong as possible in what we're doing so that we can have programs, have prevention activities that are informed by the data, so that we're trying to do things that make sense and things that are data-driven, if you will, and then determine what works. So we want to try to make sure that we identify those things. Conclusion: suicide is a significant public health problem. 10th leading cause of death, 2nd leading cause of death when you look at different populations. When you look at non-fatal, even bigger, over 500,000 when you look at those emergency department visits. Results from an interaction of different factors. So, whether those are things at the individual level, at the peer and family level, at the community level, at the societal level, all of those different kind of factors can play a role. Never one single thing that leads a person to engage in suicidal behavior, but that also leaves us with multiple opportunities to take action. There's different places where we can have interventions and try to break that cycle. And research has shown that much of suicidal behavior can be prevented. When the Air Force did their program back in the mid-90s, one of the things they saw was that suicide rates decreased by over 40%. Just by this, what they call the community-level intervention. They talked about the Air Force as a community, and they were able to drop suicides by over 40%. So you can prevent suicides. There is a broad responsibility for addressing the issue, that folks have to work together. No one person or group can do it themselves. All right, well, thank you. I appreciate your attention. Thank you guys for the invitation. As I've talked about this whole thing with the public health approach and how you can take it and apply that to suicidal behavior, hopefully you can take that and go back. So we've got a question.
Since we're recording, would you repeat the question?
Okay, yes, so everybody can hear it. Yeah.
I'm sorry.
I'm going to repeat your question just so everybody
Thank
can
you.
hear it. Yes.
I can speak loudly. Thank you for speaking today. I was the class of 68 EIS at the CDC,
Oh, my goodness.
and I followed CDC a lot through the years, and currently my big passion is prevention of gun violence. And that's the whole reason I'm here today. And you stated that 51% of cases of suicide nationally relate to a gun. You talked about paraquat. Paraquat's a wonderful metaphor for guns in this situation. I know you can't talk much about it because of the political will situation, but what's your perspective on the opportunity to reduce suicide by reducing access to guns?
I think there are some studies that I can talk about that have looked at the issue of firearm availability and other means availability. And you mentioned, I talked about paraquat, we talked about bridge barriers. I'll give you another example and then I'll get back to your question. So it's the issue of looking at firearm safety and whether that, can be one of our possible options in terms of looking at suicidal behavior. One of the things they had noticed, and so this is just another example of mean safety, is that a high percentage of the suicide attempts in the United Kingdom, in Great Britain, were due to the equivalent of our Tylenol, acetaminophen, it's paracetamol over there, that were in bottles of 50 or 100. And so people who wanted to engage in suicidal behavior, you just take the top off the bottle and you can pour it in. And so what they did is they passed some legislation that it's now distributed in blister packs. And if you're familiar with blister packs, right? You got to push out every pill. Again, it was one of those things for which I'm thinking, is that really going to prevent? Yeah, it did. They saw the number of people that engaged in suicide attempts due to acetaminophen, because it's in a blister pack, drops. Does it go out by some other mechanism? No, it doesn't. It just drops because, again, does somebody have the patience to do this? Whatever it was, there was something. So I think there are ways in which we can try to take a look at, the different kinds of means and what are some of the effective ways in which we can try to make sure that people don't have inappropriate access to a lethal means. There's been more work that has looked especially at those under 18 in regards to, firearms as a mechanism for suicidal behavior, in which they have talked about, the fact that, if you store firearms safely, which means locked and unloaded and firearm locked in a separate place, especially when you're talking about removing the access to juveniles, that can work. So we've got to take a look at, where are the ways that we can try to do that. The veterans are looking at some of that in terms of the VA is looking at some of that, and also some of the military folks in terms, I talked about, the Air Force. Air Force, that's one of the things that they're looking at too in terms of a broad approach to suicide prevention, comprehensive approach. So we're looking at a number of different things, but the Air Force is looking at the means as another option, another activity within that broad approach. So something we got to take a look at across the whole board. Yes.
So in that same sphere, the Australians, removed guns from the society. We know that gun violence dropped dramatically. Is there a statistic for suicide rates, with that intervention?
The studies that I've seen on that, there were some studies back, I'm trying to think, this is probably the 80s, maybe the early 90s. Art Kellerman, who's now out at the Uniformed Services University. At the time, I think he was with Emory University, looked at a comparison between, I think it was Vancouver and Seattle, in which he was comparing, Canadian firearm laws with the United States. These were two cities, two major metropolitan areas, northeast part of the continent, in which the firearm laws were very different, and he talked about very different rates in terms of firearm injury. And I think he looked across different aspects. So not only assault-related firearm injury, but then also self-directed firearm injury. And he found that there's a big difference there.
Last year, maybe late 2016, Mike Anestis and his colleagues did a review of U.S. gun laws at the state level and firearm suicides and found a very similar sort of thing. States with more restrictive laws regarding purchasing firearms had lower rates of firearm suicides in those states. And he's done one big study with the National Guard looking at the impacts of safe storage on suicide rates, and he's just starting a new one that has an active intervention component where they're doing lethal means counseling, and one arm they get the counseling and they're provided as many free gun locks as they need to secure the weapons that they personally own, firearms that they have at home. So those data won't be available for a couple of years, but they're working on it.
Yeah, so pointing out, some of the studies that have been done by my guesties. There was another study that has looked at it, a slightly different way, but by Cook and Ludwig, I think, in which they were looking at some of the early adaptations of the Brady Bill. And, as part, the two big pieces of the Brady Bill had to do with a waiting period and a background check. And so what they did is they looked at the influence of the Brady Bill on firearm-related, especially suicides among different populations, and they found that actually it was the waiting period that seemed to make a difference, and they said especially among older adult firearm suicides that they saw a drop because you had to wait 30 days. And so again, highly accessible. You can get one and then you could use it, within a day or within a week or that same afternoon. But waiting 30 days, dropped firearm-related suicide. So again, some of the early work looking at the Brady Bill showed some differences. That was, specifically within the United States. So there are some things that have tried to look at them. There's a question.
Can you speak to even conversations about government's responsibility to reduce risk of anything, but to reduce risk? Now, I would segue it into the gun thing, but in speaking with our legislators, is that conversation a relevant conversation when you speak outside of CDC, or in other words, you represent a division of government? Does that imply the government has a responsibility to reduce risk? Automobiles being the best example.
Yeah, and in terms of thinking about this, so part of what the question was is, where is the government responsibility to try to look at reduction of risk? And I think there are some examples in which we have tried to do that. And as you said, with motor vehicles, there's a good bit of history. You go back to William Haddon back in the 60s, late 50s, early 60s, in which we said, if we scientifically look at these things that they used to call motor vehicle accidents, right? It gives you that whole terminology in terms of an accident. You were in the wrong place at the wrong time. We really couldn't have done anything about it. But when you start to scientifically look at the risk factors and protective factors and components that go into motor vehicle crashes, you can see that, alcohol or seat belts or the way roads are designed or guardrails or the steering column or the glass in motor vehicles, that there's ways that we can design this better so that, just for example, the glass in the windshield doesn't break up into these, sharp shards, but breaks up into these little cubes. And so people don't get cut up and that kind of thing. So there are different examples in which we can say, are there ways in which we sort of suspend your individual rights to protect the rights of the community? When we say, for example, children have to be immunized to start school, well, what are we talking about there? Well, we're talking about trying to protect that community of 6-year-olds or 5-year-olds so that if we get that herd immunity up high enough, even if there's one that didn't get immunized and goes to a country and comes down with the measles and brings it back, if the other 24 children in the class have all gotten their shots and they all took, he's not going to spread it very far. So there are cases in which we do talk about, there may be examples in which we do limit individual freedom a little bit to talk about protecting the community. So there are some places that we do that. We just have to see how we can apply that across other areas, not just, for unintentional injury, motor vehicle, but are there places in which we talk about violent injury? We talk about things that, have to do with like mandatory reporting of child abuse and neglect that we make, whether it's teachers or emergency department physicians or social service folks. If you see something that looks like this was child abuse, it's got to be reported to the proper authorities that, we suspend the role of parents for some things if we think that this child is, their health is in danger. So there may be instances in which we have to see about how that applies to other areas. All right. Any more questions? You got like three whole minutes to talk about all kinds of other stuff.
I have a question.
Yes.
This may be very simple because I'm unfamiliar with the literature, but I'm thinking about the disparities that you showed at the beginning about the differences in completion rates of suicide by sex, by ethnicity, by age, by urbanicity. If you account for method choices, does that account for all of the disparities? Because I would think males are higher, but perhaps males are more likely to use a more lethal method. Rural are more at risk, but perhaps they're more likely to use a lethal method. And so if you account for the method choice, are there still the same disparities?
There's a couple of things to address in that one question, right? There's several things. I'm going to say one thing, and I don't want you to take this the wrong way, but generally when we talk about suicides, we don't talk about completed. Because we believe that any person that dies as a result of suicide, that was a failure on our part. Because then when you talk about completed, you talk about failed. And so we usually talk about they died due to suicide. So completed is just a terminology that we try to not use. But the method choice does seem to make some difference, but it doesn't explain everything. because we do know that with males, they do tend to choose more highly lethal methods. So whether that's hanging or things like firearms, it does make a difference in regards to the method that's used. One of the things that was interesting that I learned is that when you look at suicides in the military, again, a group that has a lot of exposure and familiarity with firearms, that when you look at females that die of suicide in the military, they tend to use firearms almost as much as the males do. It is not as big a difference. There's a big difference when you look in the civilian population in terms of females using firearms versus males using firearms. But in the military, it's not very much of a difference. So some of it does have to do with the familiarity maybe of that means. So that does that plays a role in part of it, but it doesn't explain all of it. There's all the socialization that you would think of. So why do males pick the firearm as opposed to picking something else? So yeah, there's some other stuff that goes into it. That is part, but not all. Yes?
So a related question that the data are always so clear on the lower rates among African Americans. What's going on there that's protected?
Gosh, so that's the Nobel Prize for the year after the other person wins it. There's Dr. Carl Bell, who's a psychiatrist, works up in the Chicago area, has always advocated that one of the things we need to look at, especially in regards to protective factors, is African American females that have, in terms of suicide, deaths due to suicide, have some of the lowest rates of any of the, especially the 5 major, racial and ethnic groups. And he said we need to be studying them more to figure out what's going on there. Some of it, he contends, and he says we really got to do the study, has to do with that social support issue, and that it may be that community relationship thing among African American females is so much stronger that it protects them against deaths due to suicide. Now, when you start to look at non-fatal, they still, as females, it's a little bit higher than some of the other groups, but it may be some of the social support. There may be some other stuff that plays a role in some of that too, but I don't think we know all of the answer to it. But yeah, the sharp contrast between females and having this higher rate of non-fatal suicidal behavior, but when you look at deaths due to suicide, males 4 times higher. That is just a big contrast there in terms of just thinking about this demographic is so different. What's happening here? But some of it may be the social support, social isolation issue, and some of it, seeking help seeking, and some of the other things are, again, what that interaction is, we don't know all of it yet. All right. Yes, sir.
You got a theory about Nebraska?
I don't know exactly what's going on in some of the different states, but one of the things that we have, again, kind of conjectured about is why those Rocky Mountain states are so high, and that issue where we showed that rural areas have higher suicide rates than other areas. That it does tend to be that those Rocky Mountain states have more rural areas. And you'll see occasionally, it kind of depends on the year, that Maine and West Virginia, which again are fairly rural states, will pop up in that top 10 or that top 13. So we think it has to do with the rural nature of some of those states. Rural being maybe a translation for access to care and other kinds of things, support for other kinds of helping services that might make a difference.
Well, but Nebraska was clearly an outlier. It was the one that didn't match the states right around it, which seems Texas, can't explain anything. but I noticed that Nebraska was a very different color than Colorado, Wyoming, South Dakota. It seemed weird.
And it's hard to say, that because states have, kind of their different local environments within that state, it may be something very different within the environment of Nebraska in terms of, their laws, their support for different kinds of things that are going on, and, whether that's clinical services, is that other kinds of helping services, social services, other things that they may be doing something very different than, their neighbors to the north, Iowa, or to the south, Oklahoma,
probably
or something.
Corn dogs.
Corn dogs could be the way you eat. That might be nutrition might make it. All right. Well, thank you very much. I know we're past the hour, so thank you again for your attention.
Thank you all for coming, and there is an evaluation form going around.